All right, well, it's 7:01 and we'll go ahead and get started. It is my pleasure tonight to introduce our speaker for this evening. Dr. Sonia Ramamoorthy is a professor of surgery and the chief of colon and rectal surgery at UC San Diego Health, my alma mater, and president-elect of the American Society of the Colon and Rectal Surgeons. She's completed clinical research fellowships and her general surgery residency at UC San Diego and did her colon and rectal surgery fellowship at Washington University Barnes-Jewish Hospital. She also earned her MBA at the Rady School of Management and her MD and MS at Boston University School of Medicine, and is also a graduate of UC Berkeley. Dr. Ramamoorthy's research interests include colorectal surgery, colorectal cancer, and the application of new technology to colorectal surgery and quality-related outcomes. She has authored over 100 papers and chapters in colorectal surgery and remains an enthusiastic innovator and educator in the field of minimally invasive surgery and colorectal surgery. We're really pleased to have her speak to us tonight, and I'll transition the meeting over to you, Dr. Ramamoorthy. Thank you again.
Thank you, Kat. Thank you for having me, and thank you all for coming in on a long weekend. I really appreciate you coming in, and I hope to make this a little bit interactive because the timing of this is perfect in terms of my incoming presidency and wanting to know a little bit more about your class, your generation, things that you want to see happen in our specialty, and hear a little bit about your thoughts on innovation and what's going on in practice out there. We don't have a fellowship, so I don't get the benefit of interacting with colorectal fellows. My key informants are people like Kat Lee, who are our former residents that have gone on to do colorectal, who we're super proud of. But I want to hear more about this. So hopefully we can make this interactive. I'll talk a little bit about innovation and some of the things that go through my mind, my experience, and then I'd love to hear back from all of you. And I'm going to share my screen. Let's see, here it is. Are you able to see this?
Yes, we can.
Coming up for you? Okay. So Kat asked me to talk a little bit about innovation and new technology in colorectal surgery. I think what's relevant for this group is to talk a little bit about how you get involved with it and some of the questions that come to mind. And what I would love to hear from all of you is where you think the field is going, and what your experience has been, at least in your fellowship or in your practice, with trying to do innovation, or what innovations you might want to see. These are my disclosures. I got involved, like all of you, very early on in ASCRS when I was a fellow, and then just kept climbing through the different committees that are out there. But one of the most important experiences for me, and probably one of the more fun ones I had, was being chair of the new tech committee for ASCRS, where you get to see kind of the new technology and innovation and work a lot with industry. So I would encourage anyone who's has this kind of interest in their career to look to the new tech committee. And we this year just started incorporating having candidate members in the committees. So definitely look into that if that's something that interests you. Given that it's Martin Luther King weekend, I thought I would put in this quote that he had here, which everyone has ideas about the future and getting involved in creating an innovation in new tech. And we need more of that in colorectal. We are historically come from people that were the first ones to do natural orifice surgery, and some of the first surgeons in the belly to start doing robotic surgery. So, and a lot of transoral surgery. So there's a lot of neat, cool things to do in colorectal. A lot of our history of the people who are former presidents and former leaders in this field were all innovators, and so I'm hoping that the next generation sort of carries on that tradition. All right, so it is ripe with opportunity when I look at colorectal surgery. There's just a ton of opportunity to do things. This is a picture of a cat might recognize some of these faces, but our minimally invasive group who started doing natural orifice surgery very early on and did kind of the first transoral appendectomy. And this was all using endoscopy and some new devices that we had been working with industry to create a gastrotomy, then get the appendix out through different types of instruments, and then close the gastrotomy and pull it out. And it was so fun because at that time it really got a lot of publicity, which was a motivator for the group. And then there was an ER episode that actually was based on what Dr. Horgan and that minimally invasive group did. So that was a really cool time to be at UCSD. But it just goes to show you that there's a lot of innovation that can be done. It's not to say that that became a standard of care. It did not, but it helped us learn a lot about the technology, the instrumentation that we might need, the risks to the patient. We did quite a few animal models, and then transvaginal surgery has become reserved for specific kinds of cases. And of course, now, we have things in colorectal, like the NICE procedure, where we're using natural orifice to remove our specimens. But when I look ahead at the next 5 to 10 years, and again, I would love to hear from all of you, I think about the different possibilities that are there. And when I look around my own institution at UCSD, there's such an emphasis on data science, right? Everything from what we're doing in the EHR, which is a tremendous amount of data points there, to the microbiome, which is an incredible amount of data, and again, everything to do with the genetics and the next gen sequencing of all our cancer patients. And so there's a ton of opportunity for all of this in healthcare, but also to direct our attention to our own field in colorectal surgery, which is one of these unique fields where we straddle cancer care and inflammatory care and endoscopy and robotics and traditional open surgery and anorectal disease and microbiome and radiation. There's not kind of an area or a part of the hospital that colorectal surgeons are not involved in. And so you're in the right specialty to do whatever you might want. These are nanobots. There is a colleague of mine in the engineering school who's wanting to do more work with us, and they do a lot of kind of wireless nanobots that people might swallow, and that might be a way to evaluate for disease or to obtain protein information, especially if we think about hospital at home. In some of the work that, for example, Leila Rashidi, Mark Solomon, this whole group of new dynamic robotic surgeons that have opened up the field of maybe sending people home right after colectomies. And so there's a way for us to keep pushing the envelope in technology. Robotics will always be there, but what about independent robots? AI, this is the black box in the operating room. And then, of course, some of the robots that might be out there. COVID was a great example of where it would have been really nice to have a robot that could walk into a very contaminated room when we didn't know much about COVID and people were worried about going in there, and have them do some of the routine care for the patients. Same thing could be true for these crazy superbugs that are out there, or C. diff. So there's just a ton of stuff to do in colorectal. So it's a great field. Oh, that's the Newsweek article for our group at UCSD that did some work. Okay, so how do we define new technology? Well, technologies that are currently developing or will be developed, which may substantially alter the healthcare environment for patients, providers, and the public, as well as humanity as a whole. And that's a really cool area to focus on. And again, it doesn't just have to be in devices, it doesn't have to be in medications. It can be, of course, in the area of data science and any other clinical realm that you might be interested in. So new technology is different from the standard of care, and that's a really critical area for us to differentiate, because, as you know, standard of care is something that's gone through systematic investigation. We know it's time true tested, and it's what the average person would do. And why does it matter? Well, for medical legal reasons, it really matters that we practice the standard of care, and that when we are innovating or when we are applying new technology, that we're going to follow the standard approach for how new technology is introduced into practice. And that is everything from clinical trials to registering it, to disclosing to the patient what we're doing. So all surgeons are innovators. I don't know if you recognize this person here, Kat. I don't know if you remember this case, but sometimes we get called into cases that we're not expecting to get called into. So this is a patient of mine who died on the table multiple times during her ulcerative colitis operations. Just the lady that had crazy protoplasm that was always a super high risk to take to the operating room. I'm sure you have encountered it or will encounter it in your career. But she finally got through she has like 9 lives. She finally got through all of that and came back years later and was pregnant and was having her baby, and she wanted to have it at UCSD where all her docs could be around. And so this is us during her C-section. She had a J pouch, and we just wanted to make sure everything went well. And of course, everything went well with mom and baby. But as surgeons, we're always innovating. It's a natural part of what we do. In the operating room, not everybody is a net or text. We have to sort of think on our toes, but it doesn't mean that we're inventing while we're operating, right? It takes years of experience to have that quick action, that knowledge, that experienced hand, and that skill to know what you're doing, even when the path that you're following is not what you're expecting to encounter. So we're all innovators, but we're also skilled with experience and have to think on our toes. I would say in the first 5 to 7 years of your practice, that's the time to become the expert, right? That's the time to become the go-to person, to have reliable outcomes for people to know you're an excellent surgeon, you're excellent your outcomes are excellent. Innovation comes up throughout your career, but should really be focused on after you've really honed your skill. And you have to approach it carefully very early on. And I've seen a lot of industry just out of enthusiasm go to our young folks and try to get them to do new things or use new technology that can get you into trouble. So just be very cautious when being approached for new things, and just use your head. Most of you are pretty smart, but early in your career, you really want to establish yourself as a good, safe surgeon. So I'm curious as to, let's go back here. So what are the ways in which you can get involved with new technology? For me, I started working with industry. I just had a natural interest in the area, and I started working when I saw something new in the operating room. I would ask about it. So when I was back at UCSF, I saw the urologist working with the robot, and it was asking a lot of questions about it, and eventually got to go to Intuitive and work a little bit on the robot. Boy, that was back in 2003, a long time ago, before it even started. And they let us kind of work on this frozen cadaver, me and Mika Varma. It was a lot of fun, but that was very, very early on. So showing an interest, being open-minded, kind of poking your head into other people's rooms, seeing what's going on. I got to get involved with the new tech committee. At that time, Peter Marcello was the chair. And he was really an exciting mentor type of person, and so many new things were being developed in minimally invasive surgery. It was a great time to be part of new tech. So industry is a great way to do it. Your society is a great way to get involved. You can collaborate if you're in an academic institution, or even if you're in private practice, but you're near an academic institution. You know, we work a lot with our engineering department, but nowadays you can collaborate with the folks that run the EMR, right? There's a lot of new ideas and new technology to be applied in that area. Or you can be someone who's an inventor and you think of your own things, and there's certainly a pathway for that. And there's a lot of colorectal surgeons that have come up with their own ideas that are developed in Alessio Pagasi, Sang Lee. I mean, I could give you any number of names of people who've really developed successful technology in our field. And so if you're someone who has that inventor kind of a gestalt about yourself, there's plenty of people to help you out there in our field who've done it and done it very well. So when we think about new tech, at least in my day and age, it was all about kind of robotics and just getting a better robot out there. But as you know, robotics is going to take off, and it'll be a platform through which we'll integrate image-guided surgery, fluorescence, lots of different things will go on in robotics. There's smartphones where we'll be able to kind of monitor patients, and patients get their data right now through their phone, but maybe we'll be doing more monitoring of their vital signs. My husband's a cardiologist. They have that kind of cool app where they're able to look at the patients being in AFib or not. Ultrasound may become part of the future, understanding more about their own data and fluctuations in their glucose. All of this stuff is both for the patient and for the doctor to be able to capitalize on in terms of improving patient care. Genomics, precision medicine, that's going to take off. As you know, we're doing some screening with the Cologuard, and who knows what's going to come down the pipeline in terms of our ability to predict illness in patients. And it may become more important as we're seeing a younger and younger group of people with colorectal cancer. Predictive analytics, we'll talk a little bit about that. Such an important area to understand a little bit about our patients' outcomes. Can we predict if someone's going to get an SSI? And can we predict if someone's going to have a respiratory event? And how would we manage that information once we have it? And of course, artificial intelligence and machine learning is a super exciting area that right now in surgery, so far, nobody is thinking about replacing us, or maybe somebody is, but it's not prime time yet. But radiology, pathology, all those fields, they are developing this technology that will act as a, if you will, a partner that'll be there with you, or a colleague, someone that's going to inform your choices and hopefully make you improve patient outcome, but also give you the ability to do better than you would if you were on your own. So I need your feedback, and this is where it might become more discussion. So hopefully you're still awake, because as we think about, and one of the themes for my presidency in 2025, I've thought a lot about colorectal 2.0, which is what's the next thing for us to think about. A lot is changing in our field. As we've had talks about watch and wait, that means 40–50% of our patients won't need operations anymore. So what does that mean for us? And diverticulitis is becoming non-operative as well, right? So what does that mean? And fewer patients are needing J pouches because thank God we're better at treating ulcerative colitis, and maybe people can hang on to their colons, and there's new immunotherapy for Lynch syndrome. So maybe they won't need a J pouch anymore. So there's a lot of diseases that we treat, which there's a rapid development of innovation in the area that is not necessarily requiring surgery anymore. Now, doesn't mean that you won't have a job. It just means that your job might change a little bit. And it's important for all of us to think about what it might look like in the future. So this is where I would love to sort of take a pause, Kat, if that's okay with you, and just listen a little bit about what all of you are seeing right now and what you might think the future of colorectal surgery looks like. Do you think you'll keep practicing the way the people that you trained with practice right now?
While the others collect some thoughts, I know from my own fellowship, like we've been starting to use like the SP robot for transanal surgery, or and then also training in TATME, and seeing how that can be an opportunity for to avoid like APR in some patients. And I think the worry is, for at least for the SP robot, that it's not actually FDA approved yet. So, how does that play a factor in terms of safety and all that? And then with TATME, there's such a big learning curve, and a small population of surgeons who are doing it well. And how do we as junior faculty want to keep those skills up while also being able to offer that to surgeons or to patients in the future? I think those are two things that came to mind for me. Looks like Julia Nugent has a question. Go ahead, Julia.
Well, not a question, just I was gonna make a
a comment.
Yeah, no worries. So I think one thing that I'm starting to see a good bit of is the advanced endoscopy component. And I think looking forward, 15, 20 years, I think one important question for our field is going to be how we interact with our GI colleagues, and how that practice for advanced endoscopy splits between us and them. Because I think that as we move more towards natural orifice surgery, or less invasive, less aggressive surgical techniques. I feel like advanced endoscopy may be up and coming and something that I think our field hasn't really tried to hold on to yet. And I don't know if we should, but I think it's something to consider.
Where are you, Julia? Where do you practice, or where do you training?
I'm at sorry, I can turn on my video too. I'm just cooking dinner.
No, it's okay. It's fine.
I'm at
They're
the
fine.
University of Wisconsin in Madison. So you can see the beautiful snow outside. Yeah, so in Madison, and we do no advanced endoscopy in my fellowship, but we have a couple excellent advanced endoscopists in the GI division. And then in Minnesota, where I did residency, we had really advanced GI endoscopists too. So we saw a lot more that they were able to treat and kind of take, I think, really great care of patients in a way that surgery maybe wouldn't have been as good for them. And so I don't think I'm getting that experience necessarily. And so I don't know if we need to, but I think it's something just to be thinking about.
I agree with you, Julia. I think we haven't really changed our endoscopy requirements, if you will, for colorectal surgery, I think since I was a fellow. And that was a long time ago, right? So if the field is evolving and we need our surgeons to evolve with it, not just to be able to do advanced endoscopy, but the technology is changing in the field. I think a lot of companies are investing in natural orifice or transanal devices, including our robotic company. We need to do better. And when I think about what's going on in my own institution in terms of the watch and wait protocol, I see a lot of near complete responses, right? And I think our field is trying to decide what to do with that. Do we do a major operation, or can we get away with transanal approaches that would assure us that we're getting any residual disease that might be left behind? So I agree with you. I think endoscopy is going to be an important skill that we need to enhance both our training in as colorectal fellows, but also as colorectal practicing surgeons, to get our skills up to where the advanced endoscopists are, at least so that we can participate in the new technologies that are coming out. Was there someone else? Arshad, did you have a comment? No? Yes, maybe. Rita?
Rita has a.
Hi, good evening. I'm sorry, by the way, if you hear my kids, but my name is Rita Belizaire. I'm a colorectal surgeon in Houston, Texas. I work part-time at University of Texas at Houston, and I just opened up my own practice back in July. But I work at the part-time that I work at UT. It's at the county hospital, and I think everybody is seeing that. We are seeing colorectal cancers in patients younger and younger and younger that are sporadic. They're not even, close to screening age. And so that's a lot. We see a lot of that at the county hospital. And so the future of colorectal surgery and some innovations that I would love to see is, other ways for detection in patients that are not quite at screening age. I think that that's probably where a lot of focus will be, is who's really at risk of these sporadic cancers that are not yet at screening age. And so I think the future is probably in better detection and earlier detection, particularly at people that are not traditionally at risk for colon cancer.
I think that's a great point. That's a really great point. I just am taking care of a young mom, just had a baby and has rectal cancer. It's really upsetting when you see those cases, but that's becoming more of what we're seeing in practice today. Then I'm almost out of that window, right? Over 50, over 60. If you finally get to that point, you're probably out of the window of some of these horrible cancers that we're seeing in young people. Anybody else with any comments? That's a great comment. All right. How about innovations that you would like to see? Anything that you can see that, God, we really need to further the field of anal fistula, or do something more for wound infections? Think about those things. I won't put you on the spot, but if you have them, feel free. And the other thing I would put out there to you, and you can email me directly, is, but what can we be doing better to prepare you for the future? A lot of what we're hearing is a lot more on the business of colorectal, which we definitely need to be doing more of that. And can we innovate? I know we all have our own little smart sets and things that we do, and I know that people have struggled with trying to share those things, but maybe what we need to do is think about how can we do billing better, and if someone's figured out billing better, how can we share that across the board, so everyone can benefit from new technologies that help with billing and coding, and improving your efficiency in your offices. All right, and then move on. So innovation's great. We discover new cures and we improve patient outcomes. We want to reduce harm, we save lives, and we elevate the human race, create connectivity, and we take care of vulnerable populations. But there's always a downside, right? For everything we do, there's a risk. And we're going to talk a little bit about that because I think it's something for us to know as we think about innovating, especially in surgery, given the environment we live in. Anyone know who these people are? Anyone? So this is Jennifer Doudna and Emmanuel Charpentier, right? They the CRISPR Nobel laureates. And who would have thought that CRISPR-Cas9 technology would be so incredibly important for almost every disease that we treat, right? The technology is just opened up a whole new area for discovery and potential cure for diseases. So it's really amazing what they've done. But who knows who this is? So this is the yin and the yang, right? So this is the Chinese scientist that used that technology to clone babies, twins, right? Lulu and Nana. I don't know if you remember this. And it was a shock to the scientific world, right? And his goal was he was trying to help, right? He's trying to clone these babies and he used this technology to try to clone them to be immune or resistant to HIV infection. But as it turned out, as reported, that the twins were born and they were okay, but they did not possess the ability to be resistant to HIV infection. But what it really pointed out is, technology in the wrong hands can go off the grid, off the rails. And this was a huge ethical debate across the globe because nobody knew this was happening. There was no regulation of this. And of course, the institution where he worked at in China said, well, they had no idea what he was doing and disbarred him, if you will, but they still let him present all his data. And he said, oh, by the way, there's actually a third baby also that we altered the DNA. And so we have to be really careful when we think about new technology, right? For all the pluses that we may hear, either from the inventor or the industry, we always have to be thinking as the doctor that we have to just make sure there's not going to be any harm, right? So when technology goes awry, there's a craziness that can happen and patients can get harmed. I love this quote from Albert Einstein. Okay, so, and this is an example, right? You can clone dogs and animals, and this is available on the net. This is a crazy use of the technology, right? That was not what those two Nobel laureates had in mind. I love my dog, but I would never clone him. Okay, how about artificial intelligence? That's a big one, right, that keeps coming up. So Vinod Khosla is the founder of Sun Microsystems, and he brings up this issue that medicine requires disruption. Entrepreneurial technologies are, in healthcare, are ideally poised for innovation and disruption. And doctors are so entrenched in their current system and dealing with the current data. Of course we are, dealing with the day-to-day issues of patient care, that they can't be part of the solution. They're not innovators. They can't think clearly to think ahead. And the ideal future state would be a healthcare system that functions outside of the physician kind of input. which is really kind of a disturbing way to think about AI, right? So here is a picture of him in case he ever comes to your clinic, just so you can torture him with no lube or whatever, because he said that about doctors. But this is sometimes how the business world thinks, and maybe they're not entirely wrong, right? Sometimes we can be naysayers, sometimes we can be blockers, and so we have to find that balance between, you know, innovating ourselves, wanting to see new technology, and then we have that unique responsibility of making sure there's no harm to the patient. And AI is going to be a really interesting for us to sort of grapple with, because for many of our colleagues right now, not quite in surgery yet, AI might represent a threat, right? Where they may find that AI actually does better than the physicians. This is the breast cancer study that said, you know, the interpretations were better by the AI than they were of the majority of radiologists, not all of them. So there was this unique group of super experts that actually did better than AI, right? But because of machine learning, we can learn from the experts, and then that AI is going to be even better than those experts. And what's wrong with that? There's nothing wrong with that. I think we'd all want our mammograms or our CT scans read by the most optimal way to diagnose an issue, if we could diagnose the issue. But it doesn't mean that AI has the interaction with patients. So we can't be resistant to technology, but we also have to think ahead and think as the advocate for our patients, not just for ourselves. Okay, and this is just a quote again from the CEO of Google, that if AI can shape healthcare, it has to work through the regulations of healthcare. And I like this answer much more. In fact, I see that one of the biggest areas for the benefits will play out over the next 20 years. So it's going to be a big part of what all of you do. And he talks recently about the work that they've done in diabetic retinopathy and its causes for blindness. But using AI machine learning, we can detect it much better than humans can. And maybe it even solves some of our access problems. Again, it doesn't mean that it's going to replace physicians, but it just may be that that colleague, that co-pilot that you have with you that helps you do your job and do it better. And do we need help? Sure, of course we need help. Look at where we are in the grand scheme of all the countries throughout the world. Somehow we're seeing deaths per 100,000 much higher than in these other countries who spend a lot less on their healthcare than we do. We spend so much on healthcare, and yet we still see high infant mortality, high overall mortality, difficulty managing diseases. So there's a lot of work to be done in healthcare in the United States. Sorry, I keep hitting the wrong button here. Okay, how about predictive analytics? That's another area of new technology that's super exciting. When you look at it, we have hindsight right now is where we are. We get all our NISQIP data, we get all our quality data, and then we go back and look at it and what can we do differently. And so then we try to change some of the data or change some of our algorithms, and then we go back and see if we made any difference. But the other thing we're doing with all of that data is putting it in to allow us to predict what's going to happen and who it's going to happen to. And then we go back and then use that data to identify people before it happens to them, right? That is the goal of predictive analytics, at least in healthcare. So has innovation surpassed our ability to manage it? Well, that's really the question. So these are all the things for all of you to think about, because you're the next generation. So yes, we may get predictive analytics. And for all of these data points that are listed here, deep learning models have achieved a high accuracy in predicting in-hospital mortality. Well, what are we going to do with that? If someone comes in and we plug it into this model and we say, hey, this person has a high mortality rate, are we going to change what we offer that person in terms of care? Are we going to call someone like Dr. Kat Lee, who will help us with the palliative approach and talking to families? And maybe that is the right thing to do, right? And if we knew that was what's going to happen, but every now and then, you know, the data's wrong, and there's that 1% that if you did everything might change it. So this is going to be, I think, something for us to kind of grapple with in the future. It's all well and good when it predicts length of stay, when it predicts readmission, and you better believe that payers are using this as well to look at which people who's in, you know, insurance are going to be the more expensive people to take care of, and who are going to be the less expensive people to take care of. Because at the end of the day, if healthcare is per profit, these are the type of predictive models they're going to want to use to help them understand it better. But as physicians, we're going to have to think about, once we have the data, what do we want to do with this information? And this is just looking back at predictive analytics and talking about how can we prevent complications in the operating room. And maybe that has to do with who's doing the surgery, or the training, or the anesthesiologist, or the amount of fluids, or the antibiotic, or the interaction of all the meds, or the patient's microbiome. There's the tons of things that may come into play here, tons of data sources, but eventually we'll be able to crank out information that will hopefully help us improve patient outcomes. So kind of rolling it all together now, when we think about innovation and new technology, and there's tons of opportunity in colorectal, and this is going to impact you, industry loves colorectal. So these people are going to be coming to you with ideas, and you may have your own ideas. How do you think about these things? Who are the stakeholders? Well, patients, their providers, scientists, industry, and government. When I think about it, these are the 5 groups that have their hands in healthcare. Patients are motivated by the desire, right? So this is the good thing about innovation. They're motivated by a desire to live and be well. So they're going to be on board with innovation. Providers are motivated by a desire to help patients. Scientists, discovery and cure. Industry are motivated by profit and a desire, sure, to cure disease, but fundamentally by profit. And government and regulatory want to limit harm and ensure safe practice and protect vulnerable populations. Now, again, that's the good. How about the not so good? Well, patients want to be well and they want to live at all costs, right? Siloed thinking. They're thinking about themselves. We saw that a little bit during COVID. Let me just go out and get all the toilet paper in Costco and leave none for anybody else because I need it for myself. It's just a natural way, right? We're all human beings. But they think that way about healthcare too. And even if that means spending all this money for the last week of their life, of course, that's what they're going to want to do. So they're motivated by their own health and well-being. Providers are motivated in a bad way by recognition, the thrill of doing groundbreaking work, celebrity status, opportunities, scientist recognition. Look at the scientists that use the CRISPR technology to create twins in an unethical way. Grants and publications, and of course, profit as well. Industry, they are the only ones that are remained steady, whether it's the good or the bad. They just want to make money. And then government tends to want to delay innovation, right? As we can see with our FDA, both because of the risk of unsafe practice, but also because innovation is costly, and they may benefit from reducing that, right? And when you think about payers, and even government payers, they don't necessarily want to pay for everybody to have obesity drugs. That will cost a lot of money, right? So they're going to start to regulate who can get it, who can't get it. So there's a conflict as to what we should do and what we can do. And the question I always ask about new technology, and I would tell you to think about it, I call it swell, but it's a way to kind of frame things in your mind. Should we do it, right? When you think about TAT&E, when you think about any new technology, why are we doing it? Who benefits? Who takes the risk? Would you do it to your loved one, right? That's if you have only 1 second to think about something, you ask yourself, would you do that to your mom or dad or your loved one? And what does the patient want, right? Always kind of the most important thing. So let's take the case of robotics. Should we do it? Most people would say yes. Why? Well, you get a minimally invasive surgery in the pelvis. Otherwise, we have to do it open. Most colorectal surgeons are not good at laparoscopy in the pelvis. Who benefits? The patient, surgeon, industry. Who takes the risk? Fundamentally in healthcare, it's the patient. Would you do it to your loved one? Yeah, maybe. If someone was an experienced robotic surgeon, I would have no problem. In fact, that would be my preference for my loved one to undergo a robotic LAR. What does the patient want? They want to be well. They want to get better, and they want to do it in the safest way. And many of them will tell you they want it minimally invasive. And, is there ECOPOS? Is there another way to do it? Well, yeah, you can do it open, so it's not exactly equivalent. And lap really isn't that effective for most, in the hands of most surgeons. So really, there is an advantage to robotics that we can't get any other way. So let's take another example. Robotics has never been shown to be clinically beneficial to other approaches, and yet we see a benefit both to the surgeon and to the patient, right? There's been harm initially in the learning curve, and I'll talk a little bit about that. But would you have your loved ones do it? Well, it depends. If you have an experienced robotic surgeon, yes. If not, no. Are patients given a choice based on that? Not really. I don't think we tell patients how many robotic cases we've done. And long-term follow-up shown it to be not inferior. All right, let's look at TATME. Should we do it? Hands up in the air, yes or no? You had a rectal cancer. Okay, I see one. I don't have the full view. Yeah, probably because the Mount Sinai people are watching. Okay, should we do it? I don't know. I'm not sure. That's my answer. I will answer for myself. I'm not sure. Why? Because we have another technique for MIS in the pelvis, but why would you do it? Maybe like Kat said, you might avoid an APR. Who benefits from it? The patient, the surgeon, plus minus, but industry. I don't know if there's an industry that's truly benefiting from TATME right now, but maybe there could be one created around it. Who takes the risk? 100% the patient takes the risk. And would you do it to your loved one? Anybody? Would you recommend a TATME for your loved ones for a low rectal cancer? Not yet, right? We don't have the data yet. Let's just put it out there. We're really not sure about TATME. It's not quite there yet. Does the patient want? I don't know if you can sell stuff to patients, right? They probably will say they don't want a colostomy. So if you tell them, well, I could do this technique that might reduce your risk of a colostomy, fair number of them might say, especially this younger population of rectal cancer patients, is there a better way to do this? Yeah, alternatives do exist. Whether it avoids an APR in the same way that a TATME does, I don't know that that's necessarily true, but if it did, then maybe it would make sense. But there currently are alternatives to a TATME approach. So with the learning curve, and I think the issue with TATME, as with all new technologies, the learning curve. To what extent can it be ethically justified for an experienced surgeon already highly proficient at a procedure to embark a learning curve for a new innovation, the benefits of which are yet to be determined and speculative, and the knowledge, the experience might be possible, but at the cost to the outcome of the patient. So there is something that we have to be thinking of again every time we're instituting new technology, and make sure that we always apply our clinical trials, our randomized control trials, a rigorous approach to the way in which we introduce technology. Now, industry doesn't necessarily want us to do that. I don't think they want us to be unsafe either, but these type of trials take a long time to accomplish, and time is money in the industry. So the only people that will kind of be the watchdogs for patients ultimately are all of you. Oh, I did not mean to do that. So what can we do as we are on a learning curve, and all of you disclose risks as vividly as benefits? Talk about this being early in your career, but that you're going to have a partner there who's very experienced, and maybe even have the experience of having your partners be the person that actually talks to the patient, and you will do your first few cases with them until you feel completely confident in how many you've done. Police the industry, right? That's our job. We got to be careful about what they're suggesting we do, what they're thinking of doing. They will come to you with all kinds of ideas, and many of them are brilliant, and many of them you will tailor to be better than what they started off, and we should be collaborating that way. So anyone who shuts the door on industry, I would say that's a mistake. It's our job to collaborate with them so that we can make our new technology better and safer, and so they have a window into the things that we're concerned about. And we have to police ourselves, right? When there's a problem or a concern about a new technology, we need to be able to say, hey, that doesn't look right to me, or what you're doing doesn't seem right, or you need to have more experience doing this. We are our proctors for each other, and there's nothing wrong with saying, I think we need to do a few more of these before you are considered safe to do it. And you're saving someone, right? You're saving two people. You're saving your colleague from getting into trouble, and you're saving the future patient of theirs. Innovate to make learning surgery safe. So that's something that we haven't talked about, and that's something that is desperately needed in our field. And I would say the robotic industry has been really good about developing simulators, but we need more of that. We need a lot more of simulation in surgery. And not just dry labs, and not using animal labs, but actual augmented reality, where we can learn from all the complications that happen throughout someone else's career, not just talking about them at M&M, but showing them and storing them in a way that we can actually do that the way that pilots do, and approach that landing exactly the way the other pilot did, to figure out what they did wrong so we don't do that. And that's how we benefit from each other's experience. I'm going to skip over this. This is just about consenting patients and collaboration. So the next generation and the need for lessons in ethics, I think we have to build in this mindset and a lot of what we do. I think we have to think about what we're doing, why we're doing, how we're introducing new technology, what is it going to be used for, who's going to benefit from it. This should be an area that we continue to develop in colorectal surgery. There's one colorectal surgeon who stands out head and shoulders above the rest, who's been involved in ethics, and that's Ira Codner at WashU. But as he's retired and moved on, we really need new people to kind of take up that charge. So in conclusion, you need a framework for new technology. IDEAL is one that's out there. It talks about the idea, the development, exploration, assessment, long-term follow-up. I use the SWELL, which is my personal ethic checklist, is simply asking the question, should we do it? Why are we doing it? Who's going to benefit from it? Who is going to suffer if there's a problem? Is there EQUIPOS, meaning is there a better way to do this, or is there an equivalent way to do this that's safer? And what is the long-term plan for studying the technique? And those are the things that kind of, in your mind, again, that would you do that to your family member, that I think keep us all safe. Really important to educate ourselves in the next generation and police ourselves in the next generation so that we keep each other safe and remain vigilant. Patients depend on us, and new technology and innovation is good. It's good for patients, good for society, it's good for us, but we have to have the guardrails up. We're kind of the watchdogs of the field and the advocates for our patients. All right, thank you. Thanks to my patients and my teachers and to the industry and my colleagues, and thanks to all of you. You're all the next generation, and I know you're going to come up with amazing things, and I really look forward to your contributions. And I'm happy to answer any questions.
Thanks, Dr. Ramamoorthy. There was a comment earlier by one of the fellows, and it's again regarding the question you had earlier about getting involved with new technology and what are the ideas for the future. So Ashley was saying that it's difficult as a fellow to get involved with industry and bring out ideas to the people who can make them happen. So while we're all sort of in this last phase of our training, how do you propose or how do you recommend we get involved in new tech and get involved with industry while we're still in training?
So there's, I think one of the unique things about the society and the specialty is there's a lot of outreach from industry, even at the annual meeting, but even before that, when you, for example, learn robotics. I don't know how many of you got to go to the robotics kind of training. We used to go to Ethicon to do our type of training in that regard. And that's kind of where it starts a little bit, where you learn how to do things, or you learn from other surgeons, and you start to get used to using new tech. And if you're talking about devices, as soon as you hit your new practice, there's going to be Medtronic, there's going to be Ethicon. They usually are very excited to meet the new surgeons, and I would reach out to them, because that's how you'll figure out if you only used a certain type of brand of something in your fellowship, but now you're going to a new hospital and they may not have that particular brand, and you have to learn how to use the new technology from a different company. That's a great way to kind of establish a relationship with a rep, and then just express interest in what they're doing and anything that's new that's out there that you'd love to learn about it. It doesn't mean you can introduce it into your practice, but it's just about learning about those types of things. I started off doing laparoscopy and using a lot of the energy devices, and really kind of calling the rep in the room and saying, oh, it'd be better if the handle was smaller. I'm a woman, I have a smaller hand. And I would talk to the Olympus rep, hey, are you guys going to make any smaller handles for the endoscopy things? And little by little, they kind of got me involved in different things in their company, just to sort of explore stuff. With Ethicon, I started working with their engineers on different things. In my own institution, I worked with some of the people that had done some of the early work with robotics. I think you just have to be open-minded and vocal and reach out, and you'll be surprised how many people come to you. There's not a lot of people that are kind of very vocal about being interested in technology. So I think as soon as you kind of throw your hat in the ring there, people will come to you for sure. And you will have a lot of wisdom to share with them throughout your career about challenges you're having with technology or things that you might have ideas about. And make sure you sign non-disclosure agreements. Don't give away your ideas for free.
And do you have a spiel or for patients when you're wanting to use a new technique or new technology, and how do you sort of educate or counsel them ahead of time while trying to encourage them to allow you to do
Sure.
something new?
I mean, I think even in this day and age, for example, we have a clinical trial we're doing on a CEA antibody, right? So the patient has to come in and get an infusion 4 days before the procedure. And so when I go in there, I'll say, look, we are learning to use this. I have reviewed all the data, and it's been used very safely in Europe, both in animals and in human studies. I don't, here are the risks that have been, cited with this technology. There aren't that many. I don't expect you'll have any problem. We've used it 2 or 3 or 4 or 5 times here, and we've not seen an issue. And here's the benefit, I think, to you. And I'm asking if you'd be willing just to talk to our coordinator about it. So the ideal situation is to study it and to have a third person there, as most clinical trials do, a coordinator that can, really inform, consent the patient. But if you're talking about using something like a technique that's not been used before, let's say you're going to do the first transanal removal of your colon specimen, you can talk to the patient like, hey, I've done colectomies a lot, but with your colectomy, we're going to do a natural, would you be interested in a natural orifice approach? And they'll say, well, how does that happen? You say, well, a lot of people have done it across the country. We're still early in our experience. We would open up that rectal cuff. We would pull the specimen out that way. We would suture it closed. And that's different than if we did it the traditional way where we'd be making an incision. I think I just tell patients exactly how it is. And surprisingly, if the benefit makes sense to them, then they're on board with it. If the benefit really doesn't make sense to them, like if I'm telling a 90-year-old lady I'm going to do some transanal approach to removing her specimen, she might not be on board with that, right? She's not really worried, she may not be worried about scars and things like, she's worried about surviving the operation. So you have to be thoughtful about who you target for new technology, new techniques. But if you have a motivated patient and you can talk them through it, I think a lot of patients you'll find will be interested in it. But then the onus and the weight of the responsibility of what you're doing is on you, right? They've trusted you, and you got to make sure you know what you're doing, that you get help if that's what you need, or a proctor if that's what you need, so that things go well.
And Retha has another question about what would you recommend for someone who has an idea but no idea where to start? Are there resources within the committee or within ASCRS to help people with exploring or developing ideas for technology?
I think the new tech committee is a great place. I don't know that they actually have that as a charge of their committee, but the people that are on there are so well versed in all of that I know if you brought that issue up, they'd be able to help you. I mean, I'm happy to help you offline, but it really does raise the issue of should we be doing a webinar in ASCRS or doing something more to help people take ideas from an idea to development to commercialization, because we have experience with people who've done that and done it successfully, and people who've not done it successfully, done it the hard way, done it the right way. And we can all learn from their experience. So if there's interest in that, I'm happy to push that idea along, because it's come up before as an interest topic for ASCRS.
It sounds like that people are interested. So
good. Okay, yeah, let's do that. Thank you, Retha.
And then for just the last question for for those of us who are negotiating and looking at jobs and looking at contracts, and how do you recommend in this phase where we're potentially trying to introduce a new tech, or we were trained in a technique or a new technology, and then the places that we're going don't have that, or how do you negotiate for the resources, or get some kind of buy-in from the whatever institution people are going to, the fellows are going to for their future jobs, and any advice on that?
That's a great question. That's a great question. Because one of my partners came in with some experience in TATME and just, unfortunately couldn't make it work at UCSD. And I know that was frustrating for them and somewhat frustrating for us too, because we couldn't help them develop it. I think the first thing is to make sure there is interest in the group that you're joining for what you want to bring to the table. So some people want to bring in a young person because of what new stuff you might have that they don't have in the group. So it may be cycle nurse STEM, or it may be robotics, or it may be your endoscopic skills that they want to capitalize on because the people across the street have someone who knows how to do that and they won't compete. So that's the type of group that would be very supportive of you innovating and bringing new technology. And they may specifically tell you, hey, I'm hiring you because I want someone who's able to do this. And in those cases, I would, it's great if it's in alignment with what you want to do. If you feel like you need more experience, then you may want to negotiate for, okay, that's great. I'm willing to do that. I'm going to need some time for more training, more proctoring, more exposure. And I'm going to need this amount of time during the year to go do those things, or this amount of support so I can fly to these center of excellence institutions to learn how to do those things. And again, keep in mind, it doesn't just have to be techniques. One of my partners came in and said she wanted to learn bioinformatics. And so we negotiated for her to get funding from the department to do, bioinformatics fellowship. So you can negotiate for all those things. If you're walking into a practice that has just hired you to just do everything and doesn't have any ideas about new technology, then you just want to float the idea and see how they feel about it. Some people would be very welcoming of someone with new ideas and innovation and want to bring new techniques. Other people might be like, oh no, we're not interested in that. And you have to decide for yourself whether you want to be there, because you cannot go do these things alone. It'll hurt you to try to go do your first TATME alone if you don't have a partner there who's going to help you get better and partner with you to get through that learning curve of doing it and help you see those cases that would be appropriate for it, all of those things. So if that's something that you have your heart set on doing, a particular technique or a specific area that a practice doesn't have, make sure you're going to be supported. It can be frustrating if you're trying to do it alone. I hope that answers the question.
Well, thank you so much. Thank you, Dr. Ramamoorthy, for sharing your evening. And we look forward to the next time and to your presidency. So,
oh my gosh,
we'll
yeah. Well, please, I tried to write down all your names, but please come find me in Baltimore. I hope I see you at Baltimore or at the Surgical Leadership Conference that's coming up in February. But thank you for spending Sunday evening with me. And again, you chose the best specialty. So I look forward to meeting you all in person in the future. Bye, Kat. Thank you.
Bye.